Hello, our webinar will begin in about 1 minute. Our webinar will begin in about 30 seconds. Hello, welcome to the California Telehealth Policy Coalition webinar, What's Next in California Telehealth Policy, AB 133, the Medi-Cal Agreement. My name is May Kwong. I'm the Executive Director of the Center for Connected Health Policy. CCHP is the convener for the California Telehealth Policy Coalition. The California Telehealth Policy Coalition is made up of over 100 statewide and national organizations that are interested in advancing telehealth policy. CCHP acts as the convener. So if you are interested in more information regarding the coalition, please go to CCHP's website, where you will find the information on the coalition webpage, or you can reach out to CCHP staff for more information on how to join the coalition. It is a coalition of diverse groups. There are no membership dues, so you are more than welcome to participate in the group. We'd like to thank our sponsors for today's webinar, AARP California, the California Healthcare Foundation, and the Center for Connected Health Policy. The purpose and key objectives for today's webinar is to discuss the Medi-Cal Telehealth Policy Agreement. An overview of the agreement will be provided, and then we'll hear from different stakeholders' perspectives and the impacts on patients. The panelist discussion will follow, and then answers for key questions, both from the panelists and from the audience. Please note that today's webinar is being recorded, and the recording will be made available later. You are all muted, so please put your questions for the panelists into the Q&A box function, which is located at the bottom of your screen. The chat function should only be used for questions, technical questions regarding Zoom. Today's agenda, first off, we'll hear from Amy Durbin from CCHP, who will provide an overview of the agreement. And then our panel will be moderated by Quinn Sheen from Test Strategies. And our speakers include Kelly Brooks Lindsay from California Association of Public Hospitals and Health Systems, Ronald Coleman from the California Pan-Ethnic Health Network, and Beth Malinowski from the California Primary Care Association. I will now turn it over to Amy.
Thank you, May. So yeah, I'm Amy Durbin, Policy Advisor at CCHP. And I'm just going to provide a quick overview of the main telehealth components in AB 133, which was signed into law on Tuesday this week. So AB 133 is a health budget trailer bill, meaning it's necessary to implement various provisions of the state budget. So it's rather lengthy and touches on a variety of different health issues. But as far as California's COVID-19 telehealth flexibilities, the bill extends those temporary policies at least until the end of next year. So that preserves payment parity for all modalities, including audio only, and for all providers, including FQHCs and RHCs, which previously this year, the administration was proposing to limit substantially. So even though this is a limited extension, it was a significant agreement between the administration and legislature and stakeholders, considering how far apart they'd been throughout the year. And it does provide a pathway to permanency as well. Another big piece of that pathway and the agreement is the requirement for DHCS to convene an advisory group to inform their longer term telehealth policies. Mainly, it seems, around what they're calling billing and utilization management protocols. So not everyone is sure what exactly they're going for there, but there's some concerns that they could try to propose some significant limitations as part of that. So it'll be an important part of next steps here in California to keep an eye on moving forward. It'll also be happening quickly as the department wants the advisory group process to be completed in time to incorporate whatever they go with into next year's budget, which comes out in January. So we're hearing DHCS will be trying to pull that group together within the next month or so to try to stay on track with that timeline. Also, there's certain stakeholders that were named in the language of AB 133 specifically that must be included in that advisory group, many of which are part of the coalition and some that will be on our panel here next as well. Just wanted to add that these groups, the California Medical Association, Planned Parenthood, the California Primary Care Association, and California Public Hospitals, they were the primary ones in negotiation with the administration on post-PHE Medi-Cal telehealth policies, as they were the co-sponsors of AB 32, which many of you know was everyone's ideal policy preference, as it would have made the temporary policies completely permanent. So it makes sense why they were named, but I know the department will be inviting others as well. So then also just want to quickly highlight that the language of AB 133 also explicitly stated that they are preserving pre-COVID-19 telehealth policies in Medi-Cal, which was also an initial concern because some of the first proposals from the department appeared to take away payment parity for store and forward telehealth, which would have been a step backwards. So it's good that they clarified that. And then lastly, the language consistent with the department's announcement in January will newly authorize coverage of remote patient monitoring as well, though the language says it'll also be subject to a different fee schedule. So with that, I think we've completed the overview. So I'll now introduce our panel moderator for today. Quinn Sheehan is a virtual care policy expert and leads digital health engagements for Tusk Strategies. Her experience includes strategic regulatory counsel on issues concerning telehealth, mobile medical applications, privacy, marketing, and consumer protection. Quinn also serves as advisor of the American Telemedicine Association and as vice chair on the Uniform Law Commission's Committee on Telehealth. So I'll hand it over to you now, Quinn, for your opening remarks and to introduce our panel participants.
Thank you, Amy. I'm really glad to be here and joining all of you. As Amy mentioned, I have the opportunity to be engaged in telehealth policies across the country, but California is really always the one to watch as the model. And I say this not only because I'm from California and take any excuse to get back there, but really because the breadth of stakeholders who have a really nuanced expertise of telehealth issues and a commitment to driving sound policy that has made the state a leader, particularly with the guidance of the California Telehealth Coalition. I'm really glad to be moderating a panel of so many of these stakeholders to talk about the agreement and what it means looking forward. So I'd like to introduce our panel now. We have Kelly Brooks-Lindsey, legislative advocate of the California Association of Public Hospitals and Health Systems, and also a partner at Hurst Brooks Espinoza. Kelly is a leading expert on California health and human services issues and is recognized within the legislature, administration, and among counties for her expertise. She is a founding partner of Hurst Brooks Espinoza LLC, which provides legislative advocacy and consulting services to public and private sector clients. She advises clients on a number of health and human services issues, including Medi-Cal policy, state budget strategy, aging policy, whole person care, and behavioral health issues. Welcome, Kelly. We are also joined by Ronald Coleman, Managing Director of Policy at the California Pan-Ethnic Health Network. Ronald Coleman joined CPEN in February 2021 as the Managing Director of Policy. He leads the organization's legislative, budgetary, and administrative advocacy portfolio and manages the policy team. Prior to joining CPEN, Ronald was the Director of Policy and Legislative Advocacy at Health Access California. He previously managed his own advocacy firm as well, and over the years has lobbied on behalf of low-income consumers, immigrants, and community of color on a wide range of economic justice and consumer protection issues. We are also joined today by Beth Malinowski, Director of Government Affairs at the California Primary Care Association. Beth joined CPCA in 2013 and advances CPCA's policy priorities and legislative interests through California Health Plus Advocates, CPCA's advocacy affiliate. In this role, Beth led recent state advocacy to maintain critical safety net funding, strengthen telehealth, and since 2015 has overseen over a dozen sponsored bill initiatives to advance healthcare center interests. So thank you all for joining us today. I know we're going to have a really interesting discussion of what the agreement's components are, ongoing considerations, and what we have to think about looking forward. But first, I'd like to give each of our panelists an opportunity to share their perspective on what this agreement means for the continued use of telehealth, impact on patients, and their engagement in the process going forward. So we'll start with Kelly, please.
Good morning. I'm here representing the California Association of Public Hospitals and Health Systems, which represents California's 21 public healthcare systems. CAPH's members include county-affiliated systems and the 5 University of California academic medical centers. Across public healthcare systems, nearly 60% of our patients identify as persons of color, and 1 in 5 patients report a primary language other than English. Despite representing just 6% of all hospitals in the state, CAPH's members provide 38% of all hospital care to the remaining uninsured and 30% of all hospital care to Medi-Cal beneficiaries in the communities they serve. Public healthcare systems serve 3.7 million patients annually, operate more than 200 outpatient clinic facilities, and provide more than 10 million outpatient visits each year. Additionally, they operate more than half of California's top-level burn and trauma centers and train half of all doctors and hospitals in the state. Telehealth has become a critical access point for our patients over the last year, and even when the public health emergency is over, it will continue to be an especially important modality for large numbers of Medi-Cal beneficiaries and vulnerable populations that public hospital systems serve. This spring, 20 to 40% of primary care and specialty care visits at our health systems continue to be virtual, and most of our telehealth visits are done over the phone. We're actually looking at updating this data to see how things have changed over the summer. Examples of the types of services that have been virtual in our systems first include talking visits. So things like changing medications, chronic disease management concerns, and pain management. Second, in terms of specialty visits, things like dermatology or post-op follow-up where you can see the patient on video or have them send a high resolution image from their cell phone and then do a phone visit. Additionally, behavioral health has appeared to be even more effective via telehealth than in person, especially for patients with anxiety. Many of our systems reported being able to serve patients via telehealth that never would have come into the clinic. It has become a very important access point for care. One of CAPH's advocacy focuses this year, and frankly, since last summer, has been ensuring that telehealth continued to be a modality for our members. Our members that own and operate federally qualified health centers were generally not able to use telehealth prior to the pandemic. The pandemic was a real game changer for our systems to be able to use telehealth. Many had to invest in the technology for video services. The administration's January and May telehealth proposals represented positive movement by proposing to allow telehealth reimbursement that didn't exist pre-pandemic for FQHCs. However, their proposals on limiting telehealth and paying less than parity were concerning. The contours of the conversation shifted during the budget trailer bill discussions when the administration agreed to extend the existing telehealth flexibilities for an additional year. Overall, we are pleased that the state extended the telehealth flexibilities in Medi-Cal through 2022, and we look forward to additional conversations with DHCS as we think about what this should look like going forward on a more permanent basis. I would also note that we have been advocating for a longer time period for the extension beyond 2022 because we really wanted to get more time in a post-pandemic environment to evaluate telehealth usage patterns as well as lessons learned. It's clear with the current uptick in COVID cases, the pandemic is not over, and we don't fully know yet what patient behavior and needs will look like in 6 months or even a year. As public hospitals and health systems think about the upcoming DHCS stakeholder group on utilization management controls, some of the key questions that we're thinking about include, how do we establish utilization protocols that effectively prevent against potential misuse, but do not impede providers' ability to effectively serve their patients? What is the right balance between in-person and virtual visits? How does this change depending on the patient or the patient's needs? For example, homeless patients, high-risk patients with multiple chronic conditions, patients with behavioral health needs, children versus adults. How should we evaluate telehealth after the public health emergency is over? What key factors should be explored to measure the effectiveness of telehealth among different populations or for different services? Thank you so much for including me in the panel this morning. I'm looking forward to conversation with the other presenters.
Sorry. Thank you, Kelly. Now I'd like to turn to Ronald for his opening remarks.
Hi, everybody. Ronald Coleman here from the California Telehealth Health Network. Thank you so much for having us here today. And so telehealth will continue to be relied on for the foreseeable future, and we must ensure that it does work for all Californians and their healthcare needs. With that said, we know that there is certainly huge potential in telehealth for communities of color. With COVID-19 and social distancing measures that have been in place, telehealth has certainly been one of the safest ways to get various patients to see their doctors and various providers. It has certainly a lot of potential in many communities that have historically lacked access to care, with more widespread use and adoption. In Medi-Cal, particularly low-income communities, including those living in rural and medically underserved areas, can now access specialists and manage chronic conditions directly from their home. Research has shown that virtual visits are comparable to in-person visits for certain services and can ease patient burden in terms of transportation costs or lost wages due to time away from work. We've definitely heard a lot of patient encounters and stories about the good benefits of telehealth and really not having to really worry about loss of wages, particularly you're finding childcare or many of the other challenges that people have faced. However, this rapid deployment of technology for healthcare is not fully accounted for the needs of Black, Indigenous, and people of color, including low-income seniors, limited English proficient, persons with disabilities, and those living in rural areas who experience digital barriers at higher rates. While the quick pivot to telehealth world demonstrates that healthcare can adapt and adapt quickly when there are external factors that make the status quo untenable, healthcare innovation must not leave any communities behind. Since before COVID-19, we've known that structural racism in healthcare creates and perpetuates deep inequities. In California, people of color are most likely to be uninsured, to lack access to healthcare providers, to lack a trusted regular provider, to report negative experiences in healthcare, and to experience poor health outcomes because of all of that. Moreover, people of color are underrepresented in health professions, resulting in frequent cultural and linguistic incongruence between consumers and providers. So how can healthcare adapt and address the deeply entrenched racial inequities? And is there broader adoption and utilization of telehealth part of the puzzle to solving that problem? While telehealth has existed for many years, research on its impact on communities of color and evaluation and its ability to reduce disparities is incredibly limited. General data is extremely limited. We believe that more attention must be paid to assessing consumer satisfaction across populations and to identify and implement best practices now in order to prevent more widespread disparities through telehealth later. Certainly evaluation was not included, a strong evaluation was not included as part of this deal, but it is something we do hope to see as the future of this conversation moves forward. The California Telehealth Health Network has fielded a consumer experience survey in September 2020 on telehealth. The survey targeted people of color and those with limited English proficiency through an online platform and was conducted in English, Spanish, Chinese, and Korean. While the survey findings are limited, since it was a convenience sample, this survey also represents just one of the biggest robust data collection measures for telehealth for people of color. And so it was about 1,660 consumers who had had a recent telehealth experience. Of these, 80% of them were from communities of color. Over a quarter of the respondents reported a primary language other than English, predominantly Spanish, but it was also followed by Chinese and Korean. Approximately a third of the respondents also identified as being disabled and another third as being LGBTQ+. 68% of the respondents had accessed primary care via telemedicine, 20% had accessed specialty care, about another 11% for mental health or substance abuse treatment. The survey results demonstrated that there's significant promise to delivering and accessing care for communities of color and for shifting healthcare to truly place the consumer at the center. Over 70% of Black and Asian consumers reported that their telehealth appointment was actually easier to keep than an in-person appointment would have been. And again, we know that whether it's family care responsibilities, transportation, or even potential for lost wages, there's a lot of impact there. And so I think for our advocacy as part of AB 133, it was certainly in conjunction with Western Center on Law and Poverty and Health Access California. And, we definitely focused in a few areas. It was choice of modality, privacy, and then also evaluation. And so just a little bit more on some of these things as it relates to access and choice of modality, ensuring audio and video ensuring audio and audio video are reimbursed at the same rate certainly was something we wanted to see make it into the final deal. We were very concerned about what it would mean for folks that only have audio only capabilities and how that might shut out access. However, the other access issue is language access. We are having significant challenges with that as it relates to telehealth, and it's a major concern. 60% of the limited English proficient individuals who responded to the survey reported that telehealth services that they received were not in their preferred language. And this appears to be less of a concern, I think, for Spanish speakers, with 75% of them reporting that they did receive services in their language. However, we did notice from other communities, it became much tougher for them to access information from their provider in language. On privacy, when we asked various respondents about, how they felt about privacy in telehealth, particularly in the API community and also American Indian and Alaska Native community, about a third of respondents reported that they didn't necessarily have a private place to access telehealth services. We also have some emerging research that we're doing now, particularly on behavioral health and telehealth, and it does look like privacy is even more of a compounded and exacerbated concern, particularly as it relates to behavioral health. Lastly, evaluation. Didn't make it in. We do hope that there's more to do on evaluation moving forward. We know that the rapid adoption of telehealth born out of the necessity from COVID-19 does present in some ways a really big experiment that we can use to understand and study the diverse communities that are experiencing telehealth, particularly focusing on communities of color and what it means to reduce disparities and improve health outcomes because of the many disparities they face from institutional and systemic racism. I think we must evaluate how intersections of geography, income, care type, and coverage type impact the consumer experience and target policy changes effectively. Evaluation should focus on access, care coordination, which can be particularly challenging when providers are also working from home, and outcomes, though, for diverse populations for physical, behavioral, and oral health across the continuum of care. Reimbursement after COVID-19, as part of this evaluation process, we do think we should look into what's happening there as well. It should not be based on a fee-for-service transactional model, but more integrated into a broader system transformation and payment reform that expands access, improves quality, reduces disparities, and provides more options for all healthcare consumers. And so again, we must collect and publicly report disaggregated data on patient, family, and caregiver experience. We know DHCS, Covered California, other major purchasers have data and publicly report data from health plans. And so, if there's a way to maximize data, particularly and get DHCS and Covered California to track data that can be used for evaluation specifically for telehealth, that would be very much appreciated. We can actually contribute to rigorous research here with the expansion of telehealth and doing these evaluations. DHCS, Covered California, CalPERS have a wealth of claims, encounter and patient data that is going to be really valuable for researchers in California and nationally to really understand the impact of telehealth and the importance of being able to use that information to inform public policy and the future healthcare delivery. And so thank you very much, and very much look forward to talking with my other colleagues.
Thank you, Ronald, and thank you for sharing that data. I hope that can be available to everybody who's listening in the future. Now I'm going to turn it over to Beth for her comments.
Hi, good morning, everyone. Thank you. There's a thumbs up if you can hear me. That'd be great. I know I was having some audio issues. Oh, awesome. Thanks, folks. So good morning again. I'm glad to be here today on behalf of California's community clinics and health centers. We represent over 1,300 health center sites in California, up and down the state, who serve over 7.4 million Californians. 1 in 6 Californians and 1 in 3 Medi-Cal beneficiaries receive their primary care through our site. insights. And certainly this has been a transformative year for our care. Interestingly, when we first started thinking about telehealth and its implications for emergencies was in the context of fires. Back in 2017, the Tubbs fire, our health centers that were impacted by those fires started to use telehealth in innovative ways to make sure the communities were still receiving care as they were evacuated or their clinicians were evacuated, or to support care that was happening in shelters. And we had the fortune of working with some of you on legislation in back-to-back years in 2018 and then in 2019, the Senator Aguirre to try to make that linkage for our state, that when we're in periods of emergency, telehealth can play a much more significant role in our delivery systems. And those bills were needed at that point because at that time, telehealth implementation was so limited in community health centers. And that was in large part because of policy limitations that were in place at that time that created environments where there was no incentive for our health centers to innovate, no fiscal incentive for our teams, and really created limitations on even kind of the physical location where our patients and providers could be to deliver those services. And all of that changed overnight in this pandemic. Early in the pandemic, we were actually able to use those prior conversations in the legislature, again, that had been built under our wildfire conditions to elevate conversations, put pressure on the administration to seek immediate approval from CMS to allow for the flexibilities that we've grown to so appreciate across our system. And certainly as we started to engage with our health centers early in that pandemic, that kind of March through June window in 2020, it became abundantly clear to us that we were finding something happening in our system that we had to not only maintain in the short term, but use to drive long-term policy, which led to many of those on this call today becoming part of a stakeholder process in summer 2020 to really elevate this issue in the Capitol, where we'd hoped to see some leadership from the administration back in 2022 to create some stability then for what would happen post-pandemic. While that did not happen, I think that certainly elevated the topic for many of us and created the environment where many of us were partnering so closely together in AB 32 and throughout this budget process in FY 21-2022 to create the policy that we are talking about today. And so again, for our health centers, it's been a year and a half of just transformation as it relates to telehealth, especially as it relates to audio only, not only in primary care, but in behavioral health as well. One of the statistics that has been just so significant for us in the policy dialogue is recognition that in the behavioral healthcare spaces where we at times suffered from 50% plus no-show rates, we are seeing that some of our health centers, that no-show rate down to 0%. In other words, every single patient moving forward with those behavioral health visits, when they know they can pick up the phone or get on that video screen and do it from their comfort of the home or from their break room in their workplace. And so that's just eliminating that barrier. And right now, of course, as we know, we have a dual crisis in our country of not only addressing our COVID-19 pandemic, but also addressing this growing behavioral health crisis we're in as well. And so seeing telehealth as being transformative, both for care as a whole, but in particular in that behavioral health space. I'll maybe end my opening remarks there and just allow us to move into questions, but just appreciate the ongoing engagement from all of our partners here today, because certainly we are entering a next phase, a new phase for this work, and it will certainly take collaboration across everyone here to make sure that, as Ron notes, we don't take any steps backwards in this next phase of the work, and guaranteeing that post-2022, we're in a policy environment that continues to transform and continues to allow for the type of access that our communities deserve.
Thank you, Beth, and thank you guys all for kind of sharing your varied perspectives here. It's really apparent from all of your comments the multiple kind of issues and factors from access to quality to cost, patient experience that have gone into kind of shaping what this post-pandemic policy should look like going forward. I think now we want to kind of shift to AB 133 itself and talk about what it did and did not address. So Kelly, your comments kind of touched on this, but one of the big problems for providers and patients has sometimes been the uncertainty around telehealth policy going forward. And we know that providers can have a reluctance to invest in telehealth infrastructure or offer more virtual care services if they don't foresee them being reimbursed. So I'd like you to kind of start on your perspective on whether the extension gives enough certainty or whether you think it's still too limiting, and any insights from you or the other panelists as to, why only 1 year?
I'm going to start with your last question first, sort of why I think it was only 1 year. I think the administration has two concerns, at least two stated concerns, or maybe implied during that came across through the budget discussions and the negotiations on the trailer bill. The first is costs. I think they're concerned that more widespread use of telehealth would increase patient volume and potentially increase Medi-Cal costs. And I think the second issue is they have expressed concerns about fraud or misuse, that providers would bill for things that are inappropriate or care that wasn't received or sort of not following existing guidance around what is legally billable. And so I think that's part of the impetus for such a focus on utilization management and wanting to put some guardrails in around the use of telehealth. I think there's also an unstated concern on their end that the longer we have the telehealth flexibilities in place, the harder it will be for them to take them away or modify them in some way. And so, I had mentioned in my comments, I don't think a year extension is ideal. It doesn't give us enough information about what telehealth looks like in a non-public health emergency environment. And I think the administration's perspective, or at least what they stated during our conversations around the trailer bill, I think they anticipated things would sort of return to normal and maybe we would have some better data and information over the summer and fall, because I think their beliefs were predicated on sort of people getting vaccinated and the COVID going away. And I don't think they anticipated the Delta variant and sort of what we're actually seeing in terms of an uptick in cases, and probably did not think through. I think they thought the pandemic was going away in some ways. And so I think that's a real question for us as we kind of head into the fall, like how the interplay between the public health emergency and then the ability to have good data around telehealth and what does that look like. I think those are sort of my initial thoughts. I would also mention, particularly for our members for public healthcare systems, some of them have been very hesitant to invest in the video technology, not knowing if it's going to be reimbursed. It's going to be a significant investment for some of our systems. And so they have relied more heavily on telephone for now. And so only the year extension probably does not give them enough certainty about whether or not to invest longer term in sort of high quality video options.
Beth or Ronald, do you have any additional comments on the certainty issue, or you can?
I'll just say that on behalf of the health centers, very similar perspective as Kelly outlined here for our public hospitals. Certainly, looking at this from maybe the glass half full perspective, there was a moment where I think some of us were concerned that the administration was going to kind of force some permanent policy in place immediately on us. And certainly the fact that we have at least this kind of full 1 year extension of all the current flexibilities is a reflection of that pushback and giving us just some time and space to have this more meaningful conversation about some really weedy issues in terms of how we approach everything from billing and coding to quality, but really agree with both the concerns Kelly and Ron have made here, that one of the limitations in taking the approach that we're about to enter into is the fact that we do not benefit from the data of a pandemic and truly post-pandemic environment, because we will still very much be in this pandemic for the period that we'll be engaging in this conversation. So just want to kind of stress that point. And acknowledge again why it'll be so important to get as many stakeholders to the table to certainly highlight as best we can, again, where the successes have been, where the complex policy needs to get built out, in the hopes that we also don't move into discussions any more quickly than we have to. And so I say that to say that maybe even there is some opening that if we think there are areas where we really should not move forward policy yet, because we're still in a pandemic, that maybe there will be some openness in the administration to revisit that. But certainly from a stakeholder perspective, we'll be going forward with a good faith effort to really talk about all of the challenge points that the state has identified for us.
So I'm going to stick with you, Beth, just for a second, as we talk about the advisory group that Amy had mentioned earlier that's already started to convene. What issues do you think stakeholders can, what are the best ways for stakeholders to engage here? And what issues do you think need to be addressed right now in terms of, you said some that we might need to wait on. Where do you think the focal point should be right now?
Yeah, I'll try to do my best there. And I want to acknowledge that currently, from where we sit, we have not started yet the kind of this next phase of the work. Certainly welcome it starting soon. And to some extent, we really don't know how this process is going to play out, because as has been acknowledged, the language is so limited in AB 133, and the limited language that is there is a reflection of the stakeholder community pushing to have more robust language than what was originally desired by the department. So one, I think just in terms of what stakeholders can be doing right now is I do think, especially for those of you that have not been named, but know that it's critical that your voice is at that table, that you're communicating that to DHCS. Right? It is so important that DHCS knows that we're all watching, that we're all eager to be in this conversation, and to make sure it is truly a robust process. I think some of us have sat in spaces before with DHCS or other state departments where maybe you have kind of a one and done stakeholder process or stakeholder meeting. And certainly we can't have that here. This is too complex. There's too many lives at stake, that this needs to be a thorough process, a robust one that happens over months to prepare us, hopefully, for some engagement that can happen through the FY 22-23 budget process and getting some firmness of policy in place through that process. In terms of thinking about kind of what are these areas of conversation, I think about everything from, as I referenced briefly, kind of coding and documentation around audio only telehealth. We don't have that in place today in the way which we know we need it permanently. Thinking about how do we refine clinical workflows, leveraging and recognizing kind of this hybrid care model for any one of our patients. It's never going to likely be in the future one modality only, right? Modalities will be kind of interplaying with each other in person, audio, video, depending on the immediate care needs and the clinical expertise of the team working with that, that individual. Certainly it's also thinking about some of the things that could be seen as ways from the state's perspective to limit cost, but hopefully we can design a way that don't limit quality or access, and thinking about everything from thinking about, where does that patient interaction start? How is it starting with what modality? Thinking about at what point does care transfer between a given modality? Again, we want to make sure there's consumer say, there's clinical say in all of this, but we know these things are on the minds of the department, and which is why it's going to be so important to have so many voices at the table. And it's also thinking about how do we maintain the quality metrics that we already have in place through a system that will be hybrid in the future. So things like vaccinations and just our metrics there and other metrics that we use to determine quality across our system, which then could actually play into payment and other things. So those are a few of the things that come top of mind, but certainly want to open it to others that have perspectives there too.
Thank you, Ronald. Ronald, did you have anything to share in terms of issues that the advisory group should be looking at? I know you mentioned a lot in your opening comments and your impactful data about some of the equity issues related to access of care and the impact on all types of communities. Do you think this is something the advisory group should be looking at? And also just interested on your thoughts as to whether the agreement kind of captured these concerns.
Yeah, I think as it relates to the agreement, it's kind of in some ways yes, in some ways no. I think, just by nature of having the flexibilities extended, still having services available for people, still having reimbursements be the same for telephone or video, I think is helpful at the moment. I mean, telephone services, including video, call, and text, require reliable internet services or other forms of electronic communications. And we know that many rural communities and underserved communities lack such stable internet connections for video. And so as the conversation moves forward, we hope that, that is strongly taken into consideration. We celebrate separately AB 156 as part of this, that did make investments to get to universal broadband, but we still have a long way to go to make sure that that's in place for people that need healthcare potentially through telehealth today. And so I'd say that given the language access issues we're seeing, with about 60% of the respondents we've surveyed that were limited English proficient saying that they didn't have access to their in their language, I think is a tremendous problem and something that we need to figure out how to fix as we move forward. If somebody's not able to communicate with their provider either through telephone or through video and not understanding what directions they may be giving for whatever they're being seen for, certainly that further contributes to the disparities we see in communities of color. And we don't want to further ingrain those disparities by not having language access services appropriately available through telehealth. Additionally, I think, as we are thinking of how needs of community members may be related to behavioral health services, I think, we do have some emerging data that there may not be as much consumer satisfaction with a telehealth visit related to behavioral health. We are digging into the details there a little bit more. On the other hand, we also know that telehealth has provided ways for people to get services that are culturally and linguistically appropriate, particularly in telehealth, because of being able to see a provider that might not be directly in their community, but does have their background and able to provide those services. And so, I think as we move forward, we just need to continue to focus on making sure that language access is a big part of this. Otherwise, many communities, a state like California with a huge immigrant population, is going to bake in some of the disparities even into telehealth if we're not able to enhance language access here.
Thank you. So, each of you, I believe, shared kind of different data on telehealth utilization or on outcomes. What data do you still think needs to be kind of collected going forward? And in your discussions with policymakers, are there any areas that you found to be particularly impactful? I know it's going to depend on who you're talking to, but looking forward, what type of data do you still think needs to be collected to inform this policy? I'm up for anyone. Let's just speak here.
I would just say that more data needs to be collected on how this is going to impact communities of color. I mean, certainly we know a lot about social determinants of health. We know how communities of color are affected. We know racism is a public health crisis. Given the rampant disparities that we see throughout California's communities of color, what can we put into place as part of an evaluation as this conversation moves forward to really understand how communities of color, which are a majority population in the state of California, how they're going to be impacted by the use of telehealth and the continuation of flexibilities. And so, certainly CPEN had released a report earlier this year. We do have another brief coming out later this year that will have some additional data, particularly focused on behavioral health as it relates to telehealth. But certainly, I think evaluation in data is something we're really going to need, particularly for everybody utilizing telehealth, but also for communities that we know have been left behind in the past.
Just agree with Ron there. I think certainly one of the limitations in terms of where we are right now is that we don't have the state committing to a full evaluation. Certainly that can change, and we would welcome that change. Certainly the state is uniquely positioned to have data sets that really look across Medi-Cal, potentially even data sets that can look across different payers to also help us in making informed and consistent policy. And so regrettably, right, we're still sitting in a place where, you know, for those in the association space, we're relying on data points we've collected from our membership, which is great data, great stories that of course we will use to inform what we do at this next table, but it's certainly not the same as having kind of those comprehensive state-led data analytics like Ron is suggesting. I do think that is still the gold standard, still what we would welcome. And I still think what the legislature would welcome as well, given their enthusiasm for those sections of AB 32. So, you know, I think that's what I'll say there is I think that we have some ways to go in collecting data across the board, both in terms of utilization and in terms of experience for both the clinical provider and even our plan partner side. So appreciate the question. And I think an area we'll continue to have to do a lot of work.
You know, and I also think, given that there seemed to be some hesitation on the administration's part around continuing to do audio only or paying parity for audio only, I don't think there's very good data differentiating between telehealth modalities, so whether it's phone only or video. And so it seems like we're in a difficult position to evaluate, you know, is the phone good enough if we can't actually parse out the data around those visits.
Right. But and what's interesting is just also is, and you mentioned this, I think Kelly, or maybe it was Beth, is the phone good enough? There's also the question of, is the phone the available modality for a certain patient, so that, you know, I think sometimes what gets lost is that the alternative to that telehealth care being provided isn't necessarily going to be the preferred modality or an in-person visit, but no care at all. And so how do we balance that consideration, you know, in the overall discussion? That is difficult, right? So I'm going to turn to kind of a different area quickly, and then we're going to go to a couple questions from that we've received. There's a part in the waiver that is hinged upon kind of a federal approval. And I'm wondering whether this is just a way out for the administration. Does the state really need the federal approval to extend audio only or payment parity policies, as long as they treat services through those modalities the same as in person? So I guess a quicker way of saying that is, you know, how much concern should there be about this tying to federal approval? Beth, do you have any thoughts on that?
Yeah, I'm happy to start on that. And among kind of the community of primary care associations across the country, this has been an area of dialogue recently, as California is now kind of part of a pack of forward-thinking states who are trying to move forward audio-only policy in particular. And so one, I'll just start by saying, we're not concerned. We're also, though, working from an assumption that new federal approvals will be needed. That is something that's very common, especially for those of us that are in kind of the FQHC RHC policy space, that federal approvals are often needed. In this particular case, we're envisioning that it's a new state plan amendment outside of the current emergency authorities that will be needed to extend it once we are no longer in a PHE, no longer in a public health emergency. You know, I will acknowledge that we benefit, right, in some ways from being with this pack of other states that'll be doing this work side by side. I do actually believe there's some states that are slightly ahead of us right now in engaging with CMS already. To my knowledge, DHCS and California has yet to begin the engagement with CMS. And we have no reason to believe that California has specifically heard any sort of mixed messages from CMS in terms of what will happen going forward, whether or not CMS would welcome or approve a state of plan amendment outside the declaration of authority space. That being said, in terms of from where we sit, recognizing how important this is to health centers and seeing this move forward, we have begun some dialogue with our national association on this, as well as some dialogue with some of California's members of California's congressional delegation to have some dialogue with CMS to make sure that there will not be any impediments there. And we are actually working with a couple of members of California's congressional delegation on a letter that would go to CMS just to reaffirm CMS's commitment in this space. So I do want to acknowledge that.
Thank you. And I'm going to take a question that we received from the audience here, and it's something that's happened on the federal level as well as the state, and it is this question about fraud. I think there's sometimes an intuition that the telehealth setting might be more susceptible to fraud just by the virtual nature of it. But there's the question was whether the administration has offered any evidence around fraud and cost concerns. So I think there's a question of, is it any different than the in-person care setting? What evidence is there that telehealth in California is more susceptible? And how have you guys pushed back against this concern if it is unfounded? Or any recommended strategies?
So I don't think there is good evidence around this concern about fraud. What the administration has pointed to is around quality. So, vaccination rates are down, and other sort of measures that they would use around quality have gone down, but we're also in a pandemic. And so it's sort of hard to argue that telehealth is the reason, as opposed to like people are afraid to go to the doctor in the middle of a public health emergency. And so I don't think, I think this is probably one of the conversations that will continue to occur with the administration over the coming next several months in their stakeholder process, and perhaps even with the legislature as well. I mean, this is why we'd like partially why we'd like the public health or the flexibilities in place for a longer period of time before and an evaluation component, so that we can sort of see what happens, with sort of with patient choice and utilization and other things. And more data also gives us a better pathway to sort of what sorts of utilization controls make sense. I think it's hard to design utilization controls in the middle of a public health emergency where patient behavior and choices are maybe very different than they would, 6 months or a year or even 2 years from now.
That's helpful insight. Does anyone else have any recommendations? I mean, I think one thing that sometimes can get lost is that, the existing protections that we have, patient protections, utilization protections, don't go out the window when you add a new care setting like this. Those safeguards are still there, but I'm wondering if anyone else has any strategies that they found effective of pushing back on this concern around fraud. Okay, we can move on. So we had another question that had to do with Medi-Cal reimbursement parity. Do any of our panelists foresee what kind of requirements Medi-Cal will want to put in place on parity?
Yeah, I think, so this is Beth, I'll start with this one. And maybe I'll start by just reiterating something that I think was said earlier in the call. But one of the things that I want to be clear about in terms of this next phase of the work is that we are not going back to the table on payment parity in concept. In terms of thinking about this extension as a period of a one-year extension versus what happens beyond 2022, one of the areas I think we feel committed to is in terms of where we left these conversations, the administration is committing that there will be payment parity across modalities. And I think what we are looking to do in this period of dialogue this fall is really thinking about what are the guide rails that exist within or across some of these modalities for when it's appropriate to use one modality over the other. But as long as we agree to those principles, ideally getting those written into statute, of course, that after 2022, as long as we are meeting those new standards and guardrails, that we will be receiving, our institutions will be receiving that same payment, regardless if it's in person, video, audio, store and forward, et cetera. So that's my, I guess, a quick comment there.
What about in person? Do you think it will continue to be allowed for both new and established patients, or will there be some type of in-person requirement after a certain period of time? Some states have been experimenting with that. Does anyone have thoughts on the in-person element?
Yeah, appreciate that, Quinn. I don't know that we are actually just as a community of health centers starting to have that conversation internally over the next couple of months about where the state might be thinking of going, and certainly appreciate you flagging that's the direction other states have gone. So certainly thinking about potential for some sort of ratio for X number of telehealth visits, there needs to be a certain number of in-person visits, or a certain balance point in terms of the pacing of an in-person versus an audio or a video. But I don't think, at least from our system, we're there yet.
Yeah, I think that'll be an interesting discussion and challenge as we think about this new world that's going to have both pathways of both virtual care and in person, and how they work together and as a complement. And I think that's the question around cost too, that both on the federal level and the state, I know they're thinking about, is this additive or is it substitutive? And that's going to be, I don't know if a year's, as everyone has mentioned here, enough time to figure out what the costs actually look like, and how we also separate out it just being more access versus, it might be more utilization, but in a positive way. Is a year long enough to figure that out? As we're running down here, I'm just interested, I know one question has been around the roles of the administration versus the legislature in kind of these discussions. Interested in if anyone has thoughts on that, particularly as we think about telehealth policy going forward. Excuse me.
I think we had a very high level of engagement from our legislative partners on sort of telehealth policy and sort of what does the future of telehealth look like. And I think folks are committed to making sure that the conversations with the administration sort of go positively. So I think we will continue to see an interest from them. I don't know what that looks like, if it's informational hearings or maybe there's bills introduced so as potential counters to whatever the administration puts forward in January. I think it's a little too early to know exactly what form that takes, but I think they will continue to be interested and want to press the administration on sort of how they plan to move forward.
And we just got one more question that I thought would be interesting. Thank you, Callie. And it is around modality. And it is, do you guys think dictating kind of whether through legislation or regulation, what modality for specific health condition is something that should be prescribed by either regulation or legislation, or something that's up to the providers as you're thinking about policy?
I think it's really difficult for a regulatory entity or the legislature to prescribe, use this modality in these cases. I know our members have, as they've gotten more experience with telehealth, have put together some clinical frameworks about sort of when they think it's appropriate and in what settings. But those may differ across systems and sort of local circumstances. And so I think it becomes fairly difficult to sort of go down that rabbit hole and start basically prescribing through either legislation or some sort of regulatory action what are clinical choices for providers. I
think we are coming up on time, so I want to thank you all today for your perspectives and insights, and I'm going to turn it back over to May.
Thank you, Quinn, and thank you to all of our panelists today. So just one moment here. We'd like to thank Quinn Sheen for her wonderful moderation, and our panelists Kelly Brooks-Lindsay, Ronald Coleman, and Beth Malinowski for their great discussion and insights into what is going to be probably a little bit of a complicated policy landscape going forward. It's still a little bit uncertain, but kudos to our panelists, the members of the coalition, and people who are attending this webinar. I suspect all of us had a role to play in getting to at least this point where we are, where we at least maybe have a one-year reprieve and not necessarily facing that cliff that I think a lot of folks were worried about, that would be abruptly ending the waivers. So there's still a lot of work ahead of us here as far as the telehealth policy discussion here in California. So stay tuned with the coalition to get updates if you would like that. So Just a few things. Again, we want to thank our sponsors for their generous support of this webinar: AARP California, the California Healthcare Foundation, and the Center for Connected Health Policy. If you are interested in more information about the coalition, please contact CCHP staff. That's our information there. You can also visit the California Telehealth Policy Coalition webpage on the CCHP website. And just again, to let you know, this webinar is being recorded. The slides will be made available as well. So just wait a few days and they'll be available on that website link. Again, thank you to our fabulous panelists and our fabulous moderator. I hope everybody has a great day and a great weekend.